This section of the lecture will review structural and functional anatomy of the lower extremity. To begin with, most people need a little brush up when it comes to the foot and ankle. If you look at the center picture, the tib and fib combine, the tibia and fibula combine to form the lower leg. The talus sits directly beneath it. The calcaneus or heel is beneath that. The cuboid bone on the outside is part of the lateral column. If you look at the upper left side picture, the lateral column of the foot consists of the calcaneus, the cuboid, the fourth and fifth metatarsals. The medial column of the foot is the talus, navicular, the cuneiforms, and the three medial metatarsals. The first ray is the first metatarsal and medial cuneiform. If you look at the pictures on the bottom, bottom left, bottom right, that's a front view of the talus on top, calcaneus on the bottom, showing functionally when the foot is supinated or the arch is elevated. There's a malalignment of the axes of motion. Those two lines represent the axes of motion for the mid-tarsal joint. The mid-tarsal joint is the midfoot of the joint. It's the separation between the talus and calcaneus and navicular and cuboid. They form a line right across the center. It's an important pivot point during the gait cycle. And as the foot supinates, there's a malalignment of the talonavicular and calcaneocuboid joint axes that blocks motion and creates stability. As the foot pronates, the axes of motion line up. They allow motion. You have a lot more movement of the forefoot on the rear foot when the foot is pronated, and that's the mechanism. To describe motion during the gait cycle, and most people are familiar with this, but it's worth reviewing, the body is divided into three cardinal planes: the frontal, sagittal, and transverse. Transverse plane rotation occurs. Sagittal plane is for flexion extension. Frontal is lateral flexion. Frontal plane motions of the rear foot are inversion, eversion. Inversion is elevated of the arch. Eversion is pronation. Abduction, adduction at the hip is also a frontal plane motion. Transverse plane motions, again, primarily internal, external rotation. Sagittal motions, flexion, extension, and ankle plantar flexion, pointing the foot down. Dorsiflexion, bringing the foot up. When it comes to the subtalar joint, that's the joint between the talus and calcaneus, there is a lot of variation from individual to individual. This is the right subtalar joint, talus and calcaneus, and if you take the talus off the calcaneus, if you look at the picture on the left, there are three separate connections between the talus and calcaneus. Those three separate connections produce a relatively stable, rigid structure. You tend to see the triarticulated subtalar joints in people with neutral to high arches. There's all these other patterns. If you go to B, C, and then D, especially you look at C, there's just two connections. The talus connects through the calcaneus through two individual points. That foot tends to have a little more motion. If you look at D, some people just have one connection to the subtalar joint, creates hypermobility of that joint, tends to be present in low-arched individuals. It's a common cause for extremely low arches. The subtalar joint has always been considered the primary connector between foot function and lower extremity function. For the past 70 years, the belief was as the foot hit the ground, as the foot everted or pronated, the tibia turned in an equal number of degrees. So as the foot pronates 8 degrees, the tibia turns in 8 degrees. That's been accepted as the norm for the past 70 years. It's been used to explain why foot pronation correlates with knee injuries, why foot pronation correlates with hip injuries, and some really great research has come out that's shown that that's not the case. The subtalar joint, when a guy named Lundgren did a study where he embedded small tantalum beads in the calcaneus and in the talus and put them on a platform and showed that as the foot pronated, the foot didn't behave as a mitered hinge. There wasn't a 1-to-1 ratio. The foot moved a lot more than the leg turned in. They said instead of calling it a torsion transmitter, call it a torsion dissipator. That pronation of the rear foot and the degree that it transferred rotation varies with arch height. People with really low arches, their foot moves a lot, absorbing most of the force. The mitered hinge analogy isn't present. You get some rotation. So say the foot rotates 15 degrees, you might get 9 or 10 degrees of tibial rotation. the opposite of that, and it's basically there's a low axis of motion to the subtalar joint. So if you look at the left side of this image, the top image, you see that 20.5 degree? That's the axis of motion for someone with a low arch. The foot will move a lot, like a hinge lying on its side, but the leg won't move a ton. On the lower portion of that, where it says 68.5 degrees, that's the location of the axis of motion in someone with a high arch. When you have a high arch, the foot doesn't move that much, tends to be a triarticulated subtalar joint, doesn't move that much. The foot doesn't move, but the tibia moves a little bit more because the axis of motion is high. It's like it just pivots about that vertical axis. When a couple of researchers measured three-dimensional motion in the lower extremity in people with different arch heights, and they showed that regardless of whether you had a high arch or a low arch, the tibia tended to rotate about 8 degrees in everybody. It's nature's way of accommodating subtle differences. If people with low arches pronated 15 degrees and they transmitted 15 degrees up that kinetic chain, everything would break. And because it happens before skeletal maturity, the structures kind of just reform. One person did a study years ago, I remember reading, where they showed that if you fuse the subtalar joint in a child before skeletal maturity, they turn their ankle joint into a ball and socket joint so that the ankle can absorb the rotation. I think the same thing happens with low arches. The structures form so that they don't transmit that potentially dangerous motion up. And the same thing with cavovarus people. High arch people, you need to rotate that leg a little. So structural changes in the foot don't play as big a role in the proximal injuries as people would think. That's why some really nice research has shown that pronation doesn't predict success with orthotic intervention for people with retropatellar pain, because they're not sending, their tibias are rotating the same amount as non-pronators. So it's a new way of looking at things, and people have come up with new tests to determine just who's going to respond to which interventions. But it really means you've got to change from looking at the foot as a mitered hinge analogy, where there's 100% transfer, to like a 60 or 70% transfer. Very important, and everybody's different. Some other great three-dimensional research has come out. Again, they surgically embed tantalum beads, and this is a frontal plane view on the left of the ankle. Surgically embed tantalum beads into the talus, tibia, and fibula. And everybody thought that the ankle would move about a fixed axis that's located in the frontal and transverse planes, which are these two planes right here. So that would just move up and down, kind of like the ankle was just a hinge. But when they put people on machines and pushed them through ranges of motion, they found, if you look at A in that picture on the left, the central axis of motion tended to be in the same spot, but that axis varied. Most of the axes went through the distal tibia and fibula. So if you look at all the lines connecting the distal tibia and fibula, you'll see that there's a pretty good, there's more axes going through those planes. But these researchers showed that the ankle also moved about almost a vertical axis. The ankle itself could spin like this. That's independent of subtalar motion. When people do biomechanical exams, they look at frontal plane motion of the rear foot, which when we do the biomechanical exam, you'll see it really doesn't mean all that much. Frontal plane measurements of the rear foot are moderately insignificant. But you need to look at what the talus is doing. That picture that I have on the right, in this study where they put tantalum beads and had people move back and forth, they showed that the talus slid off the calcaneus in a rolling action that was completely underappreciated. That rolling action produced a medial displacement of the medial malleolus. That's what Y is. That increases the lever arm body weight has for keeping the foot pinned down. It increases the stress on tib posterior, on the plantar fascia, on the abductor hallucis. When we get to the biomechanical examination section, I made a small medical device that measures that medial displacement of the medial malleolus. Very important because orthotic intervention is based on improving efficiency. Some great research is showing that orthotics don't alter three-dimensional motion as much as they alter lever arms and muscular efficiency. So as a result, orthotics should be based on measurements of leverage, measurements of lever arms, not frontal plane motions, because frontal plane motions don't correlate well with three-dimensional motion. Frontal plane meaning calcaneal inversion, eversion. As we move up the lower extremity, go into the patella, just to go over normal anatomy. The lateral and medial patellar sets, there's a little groove in there. And the trochlear groove, if you look at A where it projects, That's a left femur viewed from above. The upper portion of the femur, you'll see there's normally about 8 to 10 degrees of forward rotation of the femoral neck. That allows for almost equal amounts of internal rotation, external rotation. With femoral anteversion, the femoral neck goes forward at a much greater angle, so you get tons of internal rotation, not a lot of external rotation. Very common in women. Retroverted hips, the femoral neck, again that upper portion where the femoral head is projecting forward. With a retroverted hip, the femoral head projects straight across or even back a little. They can turn out, they can externally rotate huge amounts, but they can't turn in. People with retroverted hips tend to sleep face down with their legs like this. It can cause hip external rotator problems. People with anteverted hips tend to walk with their legs turning in. The lateral femoral condyle, if you look at A in this picture, tends to project out a little bit more, creates a buttress that stops the patella from moving. The trochlear groove is the separation between the two condyles. The patella sits in that trochlear groove. It gives it significantly more stability. This is normal anatomy as a patient is sitting down, patellar tracking. Almost every patient you're going to have in your office is going to be told, especially as an athlete, you sit them down and they extend their leg, they're going to be told that at some point or another someone said they had abnormal tracking. And in my experience, most people who are told they have abnormal tracking actually have pretty good tracking. The lateral femoral condyle, remember, is a little bit higher than the medial. So when the knee goes from 45 degrees flexion, as in the picture on your left there, when it goes from 45 degrees flexion to straight, the patella has this normal natural shift that goes around like this. It also tilts up just a little bit. It's a normal variant. It's not a sign of abnormal tracking as long as it's just a few degrees. And again, that lateral femoral condyle, if you look at A, creates a buttress that the patella has to go around. So look for symmetry between the two sides. If someone has VMO weakness or some other problem that can be causing an excessive lateral tracking, it's more pronounced and you'll see it stand out more on one side than the other. The menisci, as you look at the medial and lateral meniscus, the medial meniscus is on the right. The medial meniscus is more injury prone because it's less mobile. This is a meniscus movement as the knee moves through a 90-degree range of motion. If you look at the picture on the right, the medial meniscus moves 7.1 millimeters forward and backwards, 3.9 millimeters the posterior horn, 3.9 millimeters forward and backwards. The bottom is the posterior horn. The lateral meniscus is significantly more mobile, smaller, C-shaped, a little bit thicker, significantly less prone to injury, almost 10 millimeters of motion in the anterior aspect, 6 millimeters of motion in the posterior aspect. Patellofemoral contact points. If you look at the biomechanics of the patella is just a sesamoid bone. Sesamoid is Latin for sesame seed. Your body puts them in tendons to increase the mechanical efficiency of the tendon. Your body places its largest sesamoid bone, the patella, inside the quadricep tendon. It increases the mechanical efficiency significantly, and I drew this picture because I wanted to get a point across that the patella contacts different portions of the femur depending upon the degree of knee flexion. If you look at that top picture where the knee is almost straight, there's hardly any contact between the patella and the femoral condyle. You could have someone who's bone on bone in the patella, and as long as you give them exercises where their knee is close to being straight, they'll be able to do it. Also, if you're treating a runner who's close to being bone on bone or has like the upper portion of the patella, you can have them run with a stiff-legged short stride, significantly less pressure on the back of the patella. That middle picture B, 45-degree bend, you're dragging the patella so the central portion of the patella contacts it. Increased contact area distributes pressure very well. As you go to 90 degrees, you're contacting the upper pole. Important again because you can find which areas of the patella someone has a little problem with wear and tear and have them avoided with exercises. The lateral, collateral, medial collateral ligaments limit external rotation of the tibia on the femur. The anterior cruciate and posterior cruciate are unlocked when the leg is externally rotated. A dial test, which I'll review when we do the biomechanical examination, is a nice way to test these structures. To test the anterior and posterior anterior cruciate ligament, you'll flex the knee 90 degrees, internally rotate the tibia, look at the tibial tuberosity. It'll come under tension when the ACL is intact. it's solid, there's a nice restriction. Conversely, you can see that whole area unload. When you externally rotate, you'll see that excessive motion. If there's any damage to the medial collateral ligament or any of the other ligaments, you can tell. Dial test is good for posterolateral restraining ligaments, posterolateral ligament complex, several different ligaments, and I'll review some of those tests later on. This is some interesting research that came out of MRI studies. They had people do squats in MRIs. Most of this research is done to try to understand what's going on with artificial knee replacements, because not a lot is known exactly as what's going on in the knee. It's not a simple joint. Internal rotation is coupled with flexion, external rotation with extension. These researchers calculated the instantaneous axis of rotation and showed that as the knee flexed, there was a vertical axis, that point X, in which the condyles pivoted about. And conversely, you could see at 90 degrees of motion, there were gliding motions between the condyles that allowed the knee to flex through different ranges of motion. Again, that's relatively new research based on data from MRI studies. The vertical axis is a point of a lot of stress. Osteochondral lesions almost always occur at point X. This research explains why. This is an illustration that shows the Y ligament of Bigelow, the ligament in the front of the hip, stores and returns energy. When you're running and the leg is extended behind you, those capsular and extracapsular ligaments store some of that energy and return it back. And it just shows the development of how that twist happened when we stood upright years ago and the leg extended down. That Y ligament was placed under tension. Worked out well for us because we're always looking for free sources of energy, and storing and returning energy in the capsular ligaments, especially in this situation, the Y ligament of Bigelow, very important for stability. This is a frontal plane measurement. Again, we're just moving proximally. This is a frontal plane measurement of the femoral neck. Extremely important to measure this angle on X-ray, and no one does it. Very few radiologists evaluate this angle. It predicts stress fractures in the femoral neck in runners. Angles less than 120 degrees, which is the picture on the right, produce extreme bending forces in the femoral neck. If you have a runner with a 120 degree femoral neck angle, you have to keep the piriformis and gluteus medius strong. They support that region. The differences in lever arms, if you look at the picture on the right, that's coxa valgum. The difference, because the femoral neck angle is high, if you look as that angle goes up like this, you look at that vertical arrow on the left, it's moving closer to the center of axis for the hip. That is basically, as you go straighter up with the femoral neck angle, there's less bending force on the femoral neck, but the gluteus medius is mechanically inefficient. For 30 years, I've noticed that especially women who come in with chronic gluteus medius pain, if you ask for old x-rays they have or look at new ones, they're much more likely to have femoral neck angles in the 140, 145 degree range, because gluteus medius is mechanically unstable. It has a shorter lever arm. It's like playing seesaw where the person moves too far back. Body weight's moving back. You have to work harder to stabilize. That coxa valgum, that high femoral neck angle, is troublesome in runners because it can affect chronic strain. They're more likely to get greater trochanteric pain syndrome. They're more likely to get tendon injuries in the gluteus medius. You go to the picture on the right, you won't see a lot of high mileage runners with this angle because they tend to get problems. They'll often complain of groin pain. It's not their adductor, it's referred pain from the femoral neck. The femoral neck tends to refer to the groin. If I see that angle, I'm really cautious about having them do high mileage unless their piriformis and glute med are extremely strong. And someone years ago published a paper saying there were racial differences in femoral neck angles, that different cultures had higher and lower femoral neck angles, and someone followed up on that and showed there's no racial or cultural differences, there's urban and rural differences. People living in cities who are born and raised in cities have a more variation in their femoral neck because they're not putting it under a lot of stress, so they could have a femoral neck that's too low, which would increase the probability of a fracture. But rural areas where people do more physical labor, you tend to see fewer people with the low femoral neck angles because excessive activity, a life of increased activity can alter. I thought that was fascinating because it showed that there's no cultural differences. It's just urban and rural, and it has more to do with how much work you did during childhood. As we go up into the sacroiliac joint, how evolutionary remodeling allowed that, changes to allow for improved bipedality, huge increases in the surface of the human sacroiliac joint. If you compare the chimp sacroiliac joints, their joints are essentially fused. They're spinning from tree branch to tree branch. They don't need a lot of motion. We need a lot of motion. The human sacrum, to tolerate the vertical forces associated with heel strike and running cycle, it became more wedge shaped, which allowed for a self-locking mechanism. When you're running, that sacrum drops down into the innominate, becomes very stable, and is actually more stable as more force is put onto it. And I'll talk about it in a little while, but the human SI joint has a region behind it, the interosseous region, that can fuse later in life. Even though there's cartilage in the SI region, usually by age 60, there's no motion at all. That interosseous region, which is the large region behind that sacroiliac joint, is totally fused by the time the average person is 60. That is this section right in through here. So if you look at the shaded area in this, that if you actually took the ilium across, would be a series of mounds that lock into the sacral component, and the interosseous ligament is present in there. That ligament can tolerate tremendous stress without breaking down. It's a powerful stabilizer. It can store and return energy, stabilize in the front through the anterior sacroiliac ligament. The sacrum is an unusual bone. Structurally, it has very thin cortical bone on it. When you're running and walking, as the lumbar spine drops down on the sacrum, it's like the calcaneus. It's the only other bone in the body that has so little cortical bone and a trabecular structure inside that's stable. The bone acts as a natural shock absorber, like a marshmallow, that allows for the bone to deform with impact forces and then come straight back. The ilium, on the other hand, is very rigid. It's a very rigid structure. That's why when they looked at older people, the side of the sacroiliac joint, the iliac side of the sacroiliac joint, gets massive amounts of arthritis pretty early on, but the sacral side is protected. And that gets back to research that shows soft bones absorb force that would otherwise go into cartilage. They've shown that athletes who have osteopenia or reduced bone density, they get osteoarthritis at reduced rates. Several studies have shown that decreases in bone density allow the bones to absorb shock. Not good for runners because the bones themselves can break, but it's good for the sacrum in that it allows the sacrum to function as a shock absorber. When you do get a sacral stress fracture, it can be pretty serious. There aren't a ton of them in the running community. The literature doesn't report a lot of them. I see lots of them in my practice because I see a lot of high mileage runners, and outcomes for sacral stress fractures, if you look at the literature, aren't great. But if you treat it by mobilizing the hips, keeping the core strong, and dietary changes, outcomes are pretty good. Sacral stress fractures usually heal pretty well. This is a back view of the pelvis. The right side shows the piriformis muscle blending with the sacrotuberous ligament. As I get into the changes that happen during the gait cycle, I wanted you to see a close-up of what happens in that sacrotuberous ligament. Like in all important ligaments and tendons, it actually rotates before it attaches. It allows it to store energy from the bicep, from lengthening of bicep femoris, and it puts that energy into blocking nutation of the sacrum. When your foot hits the ground, the ilium goes one way, the sacrum tilts forward. That energy is stored in the medial, superior, and lateral aspects of the sacrotuberous ligament. That stored energy is then returned. Again, storing and returning energy, getting by on few calories is the most important thing associated with efficient bipedality. Changes in the lumbar spine that occurred with evolution. In order to deal with the extremes and vertical forces, there was a gradual widening of the width of the lumbar vertebra from T12 to L5. Allow for improved shock distribution and improved stress dissipation. The interarticular facets also started to separate. Again, spreading force over a broader area. This was our way of dealing with that large increase in pressure. As over the last 6 million years, the widening has amplified, and now we're at a point where the fifth lumbar is significantly wider than the 12th lumbar. This was a great article by researchers from Harvard. I wasn't aware of it until I read this paper. In order to provide stability during bipedal gait or when we're upright on twos, males and females have different issues to deal with. During the long gestation period, females cannot be dependent upon males to go out and get food for them, and there's an increased caloric requirement. So these researchers theorized, and they went out and proved it, they showed that women have a more wedge-shaped L3. The wedge shape of L3, if you look on the right on the bottom, allows them to have a natural lordosis that can accommodate the changes associated with pregnancy. So as body weight increases with pregnancy, the center of mass shifts forward a little bit. It requires more energy for the back extensors to fight against that. It's like a seesaw where one side is going farther forward, it's too much work. With a natural wedging of L3, it brings the center of mass back a little bit, decreases muscular strain, that allows pregnant women to walk efficiently and not have to rely on males for food. And that paper came out a few years ago, and every time I look at a side view of a lumbar spine now, I always look for wedging of L3. And again, it's more to do, if you look at C, that wedging repositions the center of mass so that the erector spinae muscles don't have to work as hard during bipedal gait. This is how your body absorbs shock during the gait cycle. Everybody has a tendency to think that the intervertebral discs are the body's best shock absorber, but if you think about it, contained fluid has little to no ability to compress. McGill was one of the first people to talk about this, and he referenced a researcher named Adams. They showed that discs aren't responsible for shock absorption. Discs are contained fluid. They allow you to move, but they don't compress a ton. They measured the vertical thickness of the end plates of the vertebral bodies, and they showed that the upper and lower end plates were less than 0.6 millimeters thick. And they showed it's like a tympanic membrane, that when vertical forces go through the extremity, it starts in the foot, and we'll go over the whole process. By the time it gets into the lumbar spine, there's still enough force to do some damage. The vertebral end plates go in the trabeculi. There are vertical trabeculi. If you look at the cross-section on the right, the vertical ones are very thick, and they bend and buckle like bamboo that's being bent, or just flexible rods. The horizontal connections are paper thin, they're hair thin. So if the vertical ones move too much, the horizontal ones stretch a little, and then they can rupture if the force is too great, but they're repaired within a day. It's your body's way of coming up with a self-repairing process to manage the forces that have worked its way through the lower extremity into the lumbar spine. So it's not the discs that absorb shock, it's up and down motion of the vertebral end plates. These ligaments, the anterior and inferior vertical components of the iliolumbar ligaments, are very important during the gait cycle, because when your foot hits the ground, there's a braking phase in which everything is stopped suddenly. And not apparent if you're just walking around, but if you're ever walking around holding a bowl of soup that's mostly full, when your foot hits the ground, you will see that bowl of soup go forward. And you'll suddenly be very aware of the braking phase while you're walking, carrying something. That braking phase, while it could cause a bowl of soup to go forward, it also causes your fifth lumbar to go forward. So once your foot hits the ground, everything's kind of stopped rapidly. Impact forces increase suddenly. We'll get into how the pelvis moves back to absorb it. But the iliolumbar ligaments, they're reinforcements that help to hold that fifth lumbar on the sacrum, stop it from sliding forward. That superior band is especially important. This is just some normal anatomy of the runners with some Latin translations. Gracilis is Latin for slender. And just look through this. The peroneal muscles along the side of the leg, peroneus longus, attaches from the fibula. Fibula means buckle in Latin, and it wraps around under the arch. The peroneus brevis runs along, attached to the base of the fifth. Tibialis anterior, very powerful muscle. Front comes from the front, attaches to the top inner side of the foot. Gastrocnemius, Latin for shaped like a stomach. Soleus, gastrocnemius crosses the knee joint. Soleus, Latin for sandal. Rectus femoris, straight muscle of the thigh. Rectus femoris is one of the 4 quadricep muscles. Very interesting muscle because it crosses the hip joint, attaches to the AIIS, and actually rotates before it attaches, so it can store and return energy. Sartorius muscle, Latin for tailor. It allows you to sit with a leg in a figure 4 position. A long, interesting muscle. Tensor fasciae lata has its only attachment to the iliotibial band. Gluteus maximus. In this illustration, if you look at the core muscles, I break down the different core muscles, internal, external, oblique. The fibers run at different angles, and rectus abdominis. If you were to take the core muscles and section them, the internal, external, oblique, EO, IO are around the transverse abdominis. Rectus abdominis is in the center. They all merge to form the lumbodorsal fascia where that little circle is. You can see MU is multifidi, erector spinae psoas, quadratus lumborum. You can see how they're powerful stabilizers. McGill talks about the importance of the external oblique muscles in stabilizing the core. Latissimus dorsi is also an important stabilizer. If you look at the arrow from B, it shows how latissimus dorsi, erector spinae, quadratus lumborum all work to create a compressive force. The external oblique in particular, the pillar, the core, outer core muscle, has a very strong lever arm for stabilizing the pelvis. During the gait cycle, oddly enough, you don't need a super powerful core. Core is really important with most activities, but when you do EMG studies of people running, there's not a lot of core activity. Your core muscles are kind of just stabilizing, they're tensing, they're holding things still, but there's not a lot of activity in them. Nonetheless, keeping a strong core is important for stability. This is a side view showing some of the different stabilizers. If you look in the middle of the thigh, the biceps femoris muscle has a long and a short head. And biceps femoris means two-headed muscle of the thigh. The short head attaches from the lower portion of the femur, gluteus maximus, gluteus medius, gluteus minimus. Very important. The medial gluteals during the gait cycle are important during the walking cycle. Gluteus max is important, really important during the running cycle when the knee flexes. The upper portion of that picture shows quadratus lumborum, a stabilizer of the low back. If you look at the woman's left foot that's in the lead right now, you'll see flexor digitorum longus. Flexor digitorum longus runs from the back of the tibia, wraps around and goes to all the toes. Very important muscle for protecting the metatarsal shafts. Possibly plays a role in protecting the tibia because it can dampen oscillations. Inner hamstring semimembranosus, tendinosis. Not as important with running. Biceps femoris is significantly more important. And then erector spinae, obviously. The upper picture on the left shows the psoas major, psoas minor, and iliacus. The iliacus muscle comes from the ilium, comes down. They all attach to the lesser trochanter. Important with external rotation. Some people feel they play a role in lessening internal rotation of the femur during the gait cycle. I'll talk about that in the patellofemoral rehab section. This is a back view. I drew this picture because I wanted to show just what the deep rotators look like. Piriformis is Latin for pear-shaped, is the upper rotator, comes from the ventral or forward portion of the sacrum. Again, stabilizes the femoral neck. And just below that is the obturator internus, externus, gemellus inferior, gemellus superior. The obturator internus comes from inside the pelvic bowl. Very important muscle in runners. You cannot get at it with massage because it comes from inside the pelvic bowl. A study of elite soccer players showed that obturator internus was often under so much pressure that it formed a bursar behind the point where it bent around the pelvis before it went forward just past the obturator foramen. That bursar shows up as a light spot on the MRI. It's a common problem to have pain in there. There's some great muscle energy mobilizations that I'll show you to loosen up the obturator, but you've got to have an awareness of the anatomy of the obturator internus and the gemellus muscles Quadratus femoris is just below that. I drew that back foot on the bottom on the person to show the connection between flexor digitorum brevis and the plantar fascia. I cut and reflected the plantar fascia and showed the flexor digitorum brevis beneath it, and flexor hallucis longus was right next to it. Flexor hallucis longus is an interesting muscle in that it runs from the fibula, comes down and attaches to the great toe, affects how the fibula moves during the gait cycle. It actually pulls the fibula down, increases depth of the ankle mortise, providing stability. Gastrocnemius, if you look in that lower picture, I've cut and reflected it so you can see the plantaris beneath it. Plantaris, relatively unimportant muscle for producing force, but some new research is showing it's loaded with proprioceptors, gives a lot of position sense information. Soleus, Latin for sandal. Gastrocnemius and soleus do two totally different things. I'll talk about it later in the normal anatomy section. And I put adductor longus in this and adductor magnus. Adductor magnus, some people refer to as another hamstring muscle because it attaches so low. Adductor longus is active constantly during the gait cycle, except for a brief period in mid-swing when everything quiets down. Interesting muscle because its architecture is unusual. About an inch past its origin, it tapers so it's only a few millimeters thick. When people get groin injuries, it's almost always in the adductor longus muscle, and I'll go over that in the injury section. But these are the primary muscle groups associated with running. I just wanted to show this picture because a lot of these muscles people get confused by. You can't see where they attach. There's a lot of names, and there's so many muscles. You've got to know the origins, insertions of every muscle. When it comes to the lower extremity muscles, in my opinion, you have to know the origins and insertion of them. Flexor digitorum longus runs from along the back, that picture on the right. You can see it attaching to the whole back of the tibia. Flexor hallucis longus from the whole back of the fibula. You can, if someone has limited MTP, first metatarsophalangeal joint motion, you can access flexor hallucis longus by getting your fingers in there. If you know where it attaches, you can get under the gastrocnemius and do deep tissue before you do muscle energy. Can lengthen flexor hallucis. I recently had an athlete with chronic fib pain. No MRIs were fine. Everything was fine. She had a problem with the flexor hallucis brevis, tendonitis up high, chronic myofascial pain in it. Couldn't get at it with conventional massage. I dropped my hand along the back. I'll show you how to do it. Access the flexor hallucis longus while lengthening the toe. You can do active release. You can do any approach you want, but you have to understand the origin. Peroneus brevis, if you look at that picture on the right, mid portion of that fib down a little bit lower. The interface between peroneus longus and brevis is occasionally a fracture site because these two muscles do different things, and different pulls can create different stresses on the bone. Sartorius, gracilis semitendinosus, pes anserine, goose's foot. Should know where they are because bursa forms underneath them. You've got to know the origin, insertion, follow the muscles back and forth. You'll be able to release them a little bit better. The lower picture on the right, I just drew the arrows to show where the different tendons are being pulled. And a picture on the left, tibialis anterior attaches to the front of that tib. Extensor digitorum longus is up a little bit higher. Extensor digitorum longus, because it crosses multiple joints, is more prone to breaking down and is more prone to respond to deep tissue massage and lengthening. Almost everyone who complains of anterior compartment pain, it's usually not the tib anterior, extensor digitorum longus. If you know the anatomy of that muscle, you'll be able to isolate it a little bit better. When we go into the intrinsic muscles of the foot ankle, and the foot itself rather, you really want to know flexor digitorum brevis. It's a powerful stabilizer of the plantar fascia. People with plantar fascial injuries respond well to muscle energy stretches on it. It sits just beneath the plantar fascia, as I showed in that other picture. Abductor hallucis muscle, pictured on the left, an important muscle with arch pain, but nothing compares to flexor hallucis brevis. Almost everybody that comes in with a sesamoid injury or limited first MTP motion, you will have to know the origin. It comes off that cuboid, deep tissue massage followed by muscle energy. Everybody knows that if you have a tight quadricep, you'll have chronic retropatellar pain. It's a predictor of chronicity with knee pain, more so than Q angles. You will intuitively lengthen, and you'll know from a professional point of view, you've got to lengthen the quadricep, vas lateralis, rectus femoris, all the quads. When you're dealing with any forefoot injury, especially a sesamoid injury, You've got to know where that flexor hallucis brevis runs. It runs at a slight angle compared to the plantar fascia. I'll do a close-up on it when we're doing some length assessments later on. Deep tissue massage followed by lengthening can lessen recalcitrant sesamoid pain when all other interventions have failed. Very easy to measure objectively. Measure the first MTP dorsiflexion, simple, and use a goniometer. You can send a person home, show them how to do it, and measure improvement. And when you restore motion, almost always the chronic sesamoid pain is resolved. You have to be careful with it because you can irritate the sesamoids doing it. That concludes the chapter on normal anatomy. The next chapter is on what happens during the gait cycle.